Peter Tran, a medicine student at Macquarie Medical School. Today, we're reviewing the best available evidence on the diagnosis and prognosis of acute appendicitis. As a palliative care clinical nurse specialist who has experienced appendicitis firsthand, your insights are invaluable in blending evidence with compassionate care. Let's first begin with diagnosis. Acute appendicitis is diagnosed by synthesizing patient history, physical examination, laboratory tests, and imaging studies. Evidence from the American Family Physician article, Acute Appendicitis, Efficient Diagnostic and Management, the similar paper from 2018, shows that clinical features include history and symptoms. Patients typically report right lower quadrant pain that migrates to the periumbilical region, along with anorexia, nausea, and vomiting. Physical examination findings, such as right lower quadrant tenderness, abdominal rigidity, and signs like psoas, obturator, and Rovsing signs are crucial. For example, right lower quadrant pain has a positive likelihood ratio between 7.3 and 8.5, meaning it greatly increases the probability of appendicitis. Abdominal rigidity and pain migration have likelihood ratios of 3.8 and 3.2 respectively. Clinical decision rules like the Alvarado and the appendicitis inflammatory response scores are used to stratify risk, and ultrasonography is recommended as the first-line imaging to minimize radiation. Let's quickly appraise the evidence. The critical appraisal guidelines emphasize comparing test findings with a proper reference standard, using blinded assessors and enrolling patients consecutively. For acute appendicitis, the gold standard diagnostic test is the surgical removal of the appendix, followed by histopathological examination. The similar paper meets these criteria, supporting the reliability of reported likelihood ratios and protocols. For you, this integration of clinical intuition and validated scoring systems not only refines diagnosis, but also offers a practical tool to interpret findings in real time. Turning to prognosis, early diagnosis and timely intervention are key. The similar paper shows that if treatment is delayed beyond 48 hours, the risk of perforation rises significantly, leading to longer hospital stays, more complications, and increased morbidity. A meta-analysis within the paper found that patients with uncomplicated appendicitis managed with IV antibiotics have a resolution rate of about 73%, although roughly 40% may eventually need surgery. These findings help guide decisions between early surgical intervention and conservative management. Using the critical appraisal guidelines for prognosis, we see that the similar study enrolled a representative patient sample early in the illness, provided clear follow-up, and minimized loss to follow-up. This robust methodology enhances confidence in its prognostic indicators. Given your background, not only as a nurse, but as someone who has personally experienced acute appendicitis, understanding these indicators is crucial. Your ability to communicate these outcomes in a culturally sensitive way, considering your experience as a Chinese individual who migrated to Australia, can empower patients and families to make informed decisions. Thank you for your attention. I hope this overview clarifies how evidence on acute appendicitis can guide both diagnosis and prognosis, ultimately translating into timely and compassionate care. Stay well and keep up the great work.